Good evening. I'm the NEET Core Team Leader, Astron Institute of International Study, Gurgaon. Today we have webinar on cervical cancer. So before starting the webinar, I'm just going to give you a short introduction about my company. We are Astron Group. We are 18 years old company focused on planning, designing, also doing quality and accreditation for the hospital by doing NABH and JCI. We are offering 50 plus certified and diploma programs for nurses, paramedical technicians, adopting a blended approach with major focus on practical learning through on-job training. Right now, more than 10,000 plus nurses are certified and well placed at national and global level in reputed organizations with the NABID, ISO 17024, and also proud to tell you that now we are training partner with Skill India. So now I would like to introduce our academic expert, Dr. Rita Lakhani ma'am. She has 26 years of professional experience in faculty and clinical positions experience. Her, uh, her achievement is Best Principal Award in 2021 by Excellent and in 2022 by NOI, Nursing Teachers Association of India, and in 20 by TNAI. She received the first prize in teachers category amongst all faculties at MUHS for research presentation during Abhishek Convention 2010 and 2015. She research guide for 2 international students and she is associated with Infusion Nurse Society, TNAI and CAHO. So now I would like to welcome ma'am. Rita Lakhani ma'am, it's over to you.
Good evening to all of you all. I think at the first place, let me thank the team at Astron for giving me this wonderful opportunity to present my thoughts on this topic, cervical cancer nursing perspective. So, how many of you all have joined in? I can see 26 participants out over there. So maybe around 22, 23. How are you all? Are you all good to go? Will you all chat with me in case if I ask you all a few questions? Participants, will you all be able to chat with me? Will you all be able to share your thoughts on chat in case if I ask you all any questions?
Yes, ma'am, sure.
Wonderful. Thanks so much. That is SO and Annie. Thank you so much. Yeah. So something very interesting about cervical cancer is it is the only cancer that is being called by WHO for eradication. I think you must have got that short, brief clip of mine which said that yes, the only cancer that's called for eradication. And you must be wondering, to eradicate something, the disease must be subtle, the disease must be clear. There must be some kind of a bacilli. That bacilli should be must be removed. So what's there in cancer? How can we remove it? And that's the great thing for today. So let's go ahead and see what's there in cervical cancer and how we can join hands to eradicate it. This is what we're going to run through for the next hour's time. We will just see why cervical cancer an important problem. If it's called for eradication, which means it's an important problem. But why is it an important problem? What is the brief anatomy behind it? What are the types of cervical cancer? What is the epidemiology, the pathology, and the signs and symptoms of cancer? What is the natural history of this disease? Once we know the natural history of the disease, will we be able to think of how to eradicate it? How and when we can prevent it? What does this WHO call for elimination? How can you screen for cancer? What is this HPV vaccination that's come in a big way now? And what is the medical and the nursing care for these patients? So let's start off. Yeah, nobody likes statistics, but I like interpreting statistics. So when the statistics came in front of me for the first time and I was making this presentation, it is said worldwide 6,62,301 cases per annum. And in India, it is 1,27,526. Now, if you multiply that 1,27,000 by 5, that means India is contributing 1/5 of the world's cases. Massive number. We are giving the world 1/5 of cervical cancer, and I just wonder why. Okay, let's look at the deaths. The deaths worldwide are 3,48,874, and India's death rate is 79,906. A little less than 1/5, but yes, huge contribution about death also. So, I've put it very subtly over here. India contributes almost 20% of new cases annually. It's heartening today, the number of cases are steadily declining. It is disconcerting that the age standardized incident rate in India is still 18 per 1 lakh women years, well above the current target of 4 per 1 lakh. So WHO has called for a target of 4 per 1 lakh women years, but today we have 18 and we have a long, long way to go to reach there. Fine. Something more, just to know a little bit burden of the cervical cancer to understand, is it a real problem? So it has been said worldwide it is the fourth most common cancer in females. So look at this figure that's there below the pie diagram. Breast, the pinkish color, lung, the bluish color, colorectal cancer, the yellowish color, and a goldenish color is cervical cancer at the world level. When it comes to India, look at it. Breast cancer is still the leading cause of cancer in India as well as in the world. But cervix is the second leading cause of cancer in India amongst women. And that's something alarming for us. Abroad, it was lung, it was colorectum, and then it was cervix. But in India, it is the second leading cause of cancer, second leading type of cancer in India among female. Now let's look at the etiology. The etiology is also very interesting. WHO in 1996 declared HPV as the major cause of cancer. So, so there's something that should strike you very, very strongly. If you have 10 women around you, to get it for sure that there would be about 9.5 of them. You would wonder how 9.5, how can you have a half woman? But statistically, yes. So you would have about 9.5 women whose cause for cervical cancer was HPV. And were this lady to know that it is HPV, so when this HPV was actually striking her, she could have gone for it to get this HPV out of her system. Let's go ahead. The WHO's International Agency for Research on Cancer, IARC, has classified HPV into three groups. Very, very significant for us to remember this. Carcinogenic is type 16 and 18. So there are many, many different types of HPV viruses, but 16 and 18 is definitely carcinogenic. Probably carcinogenic is 31 and 33. Possible carcinogenic is all other HPV types except 6 and 11. And something to remember is 6 and 11 causes genital warts and condyloma acuminata. So when I tell you about the etiology further, I will tell you women who contact sexually transmitted disease have got high rate of developing cervical cancer. But incidentally, those who have got 6 and 11 of a lower strain or a higher strain will certainly not get it. But 6 and 11 have been almost eliminated, but they have been called today as possibly carcinogenic if the virulence of the strain is very, very strong. Fine. So the etiology was very clear in the previous one. And I've told you the commonest strain is 16, and 80% of the cancer cervix specimens are having 16 HPV strain. Type 18, which is highly again carcinogenic, is seen in some cases and usually affects the endocervical glands. The other types that are involved are 31, 33, 51, 53, 35, etc. In developing countries, type 35 is second to type 16. So we have 16 and 18. In developed countries, 16 and 35. Great. Let's run through a little bit of this anatomy and physiology, which is very simple. So we know that that's the uterus right on top. We have the cervix in between and the vagina. So per vaginal examination is done, and when we do per vaginal examination, we directly come to the external os. So before we go to the external os, let me take the second picture. So we have the ectocervix, so we can feel the ectocervix in the vagina, and then we have the endocervix and the endocervical canal. Endocervix is the lining of the endocervical canal. Fine. Now we have the internal os right on top of the cervix and external os externally. So I normally when women come for delivery, we see for the dilatation of this os, cervical canal. Fine. Now when you look at the endocervix, you will find it's not very, very smooth. You find it's like a brush border. And this is called as endocervical crypts. Now, these endocervical clips are lined with columnar epithelium. Each of the script throughout, right from top to the bottom, is being lined by columnar epithelium. This columnar epithelium is giving it more an appearance of a brush border also. And of course, there's plenty of blood supply of capillaries near the surface. Now, when you look colposcopically, you will find it's more like a grape-like structure that's out over there in the endocervix. So we will remember columnar epithelium. Now, when you look at the ectocervix vis-a-vis endocervix, the ectocervix is nice and smooth and it is made up of squamous epithelium. That was columnar, this is squamous. Now, when you look at the next adjacent picture out over there, you will realize that the basal cell layer is more roundish. It becomes more flatter as it comes to the superficial layer, and it has got a very small nuclei with a huge cytoplasm. So the nuclear cytoplasmic ratio, which was very narrow at the basal layer, becomes very wider when it comes at the superficial layer, and superficial cells are more flatter. Something significant that we need to note, that when we attain menarche, during menarche, the inner layer that was there, that's the columnar layer, ectropions outside. So you can see in this lower picture, the columnar epithelium is ectropioning outside at the lower level. You can see it. So you can find the squamous layer that was there and the columnar layer, the initial squamo-columnar junction, the initial prior to menarche squamo-columnar junction is shown on the left hand side. Now the columnar cell comes out, ectropions out. So you find the columnar squamo-columnar junction has become larger. This is under the effect of estrogen. Now, when the columnar junction has come out, it cannot withstand the acidic media that's there in the vagina, and then it changes back again into the squamous epithelium. Now, when it is changing, let us remember it is called as metaplasia, because metaplasia refers to transformation of one mature form of epithelium into another mature form of epithelium. First we said the columnar came out. Now this columnar cannot remain in this environment. So it transforms back into the squamous epithelium. So the original squamo-columnar junction, which had moved out during menarche, now further comes down back again. So this area, which has got metaplasia of the cells from the columnar to the squamous, is called as the transformation zone. Very significant for us to remember the third significant point. The first significant point I told you all, it is called for elimination. Second significant point I've told you all, 16 and 18 HPV strain cause cervical cancer. Third thing I'm telling you all, this is called as a transformation zone, and most of the cervical cancers happen in the transformation zone because the cells have undergone metaplasia. And whenever we talk about cancer first stage is moving on to metaplasia. There is dysplasia going on to metaplasia. Here, metaplasia has occurred universally in all the women, including you and me, when we attained menarche. That is, the columnar first came out, columnar could not stay, it went back and became the squamous. And that area is called as the transformation zone. So far, what I've covered for you all is what is endocervix. What is a squamo-columnar junction? It was very close. Then it went beyond into the ectocervix. Then it reversed back. So there's a transformation zone. And then I've told you what's the normal ectocervix. Wonderful. So let's remember, cervical cancer originates in the cervix. It is one of the most common cancers in women. Of course, after breast cancer. We have seen this earlier. and it usually results of HPV infection. And as I've told you all, that 80% of all the cancers are by the strain 16, and the remaining 20% are because of strain 18 in India. So if I have to take 100% of 100%, 99.5% would be because of HPV vaccine, and another small number is because of other causes that I'll be discussing with you all later. And let's remember this person, Henrietta Lacks. Henrietta Lacks is played her cells have played a significant role in research in unveiling a lot of myths about cervical cancer. So hers were the first human cells that were grown in the lab, and they are still used around the world to really unfold a lot of things that are still unclear about cervical cancer. So let's go ahead. Let's understand about the cell cycle. What happens that the cell goes into, and cell goes into some kind of an abnormality which we call as dysplasia, and then why does a cervical cancer occur? So normally all cells go through a growth cycle. There is a definite growth cycle. They are in a GO phase, that is resting phase, where they are building up their proteins, they are building up everything, and they are resting. But when a given area requires a cell to regenerate, they become two daughter cells. So you have a G1 phase, you have S phase, you have G2 phase, and then go back again the M phase. So now during this phase, let us remember there are many checkpoints, all DNA damage checkpoints, DNA replication checkpoints, what is the cell size, other proteins, everything. So 3 points of check, and in spite of that, this cell escapes and becomes cancer. So what is it? Fine, something happens. So something happens, these cells go deranged, they multiply faster, and they are abnormal cells going into cervical cancer. So what's it? Let's have a look at it. So dysplasia in the epithelial layer of the cervix is also called as cervical intraepithelial neoplasia, CIN, or squamous epithelial lesion. It will usually start, look at this picture, in the basal layer. So the stain is different. It is purplish in color. So it starts in the basal layer of the transformation zone, typically in the immature squamous epithelium. I told you that the basal layer, they are more immature. They become mature when they come on the topmost layer. So it starts in the basal layer, and I've also told you all it is caused because of HPV vaccine. Sorry, it is caused because of HPV strain. I've also told you all half of all cervical cancers, more than half of cervical cancers are because of the 16 strain. There are about many HPV strains that are linked to cancer, but 15 of them are very common. I've told you all about 12 of them. Fine. Let's go ahead. Let's remember that it starts at the basal layer. Now, the virus, as it comes and sits in the basal layer, the virus is like a guest who's come in the house. So you enjoy your guest for about a day or two, but after some time you want the guest to go. And that's a normal phenomena that's there everywhere. Guests are fine for a certain period of time. Now what does this guest do? They are there and they are using the kitchen to make their favorite foods. So it is going to insert itself into the immature squamous cells at the basal layer, and it integrates its own DNA into the host DNA. Now you can imagine in the cervical layer, we have our own DNA. The HPV introduces its own DNA, and now when it has introduced its own DNA, it is going to use huge amounts of two proteins, that is E6 and E7. So it is going to produce a lot of these proteins. These proteins are further responsible for pushing mature squamous cells through a cell replication cycle, but they're blocking the activation of tumor suppressor genes P53, and the end result is there is uncontrolled replication of the cervical cells, and there is resistance to apoptosis. Apoptosis is normal cell death. So the cells will not go through death, they will not go through programmed cell death, because normally when in my body abnormal cells are produced, my T cells, other helper cells will come in cleavage and remove it out. But this is not. This is not going to happen. So I repeat myself once again. So when this when this HPV virus has come in, it is going to introduce its DNA into the cervical cell's DNA, and then it is going to produce a large amount of E6 and E7, which is going to suppress my tumor suppressor genes, and there will be, so the checkpoints are all now as though not working. So, when you look at the gradings or the stages of cervical cancer, normally you will see a couple of different ways of describing the stages of cervical intraepithelial neoplasia, CIN, but the most common is how much of epithelium is involved. So, when you look at the first one, about 1/3 is involved, you would call that as grade 1. When about 2/3 is involved, you would call that as grade 2. When about almost just the topmost layer is remaining, you would call that as grade 3. And when almost all the layer is covered up, you would call that as carcinoma in situ. That means it is in that area. When it moves out into the area where is subcutaneous tissue, and it moves further, then you would call it as invasive cervical carcinoma. So a carcinoma in situ, moving on to invasive cervical carcinoma. And when it becomes invasive through the blood, through the lymphatics, it can move. It can go behind to the rectum. It can go above to the uterus. It can go even to the bladder. It can go move further ahead, go to the liver, go to the lungs, so on and so forth. So these dysplastic cells have now become completely abnormal in the region where it is called as carcinoma in situ, moving on to invasive carcinoma, where the entire epithelium is involved. So again, the same picture I've tried to put in over here. Here I've put it in gradings. Here I've put it in CIN. CIN is cervical intraepithelial neoplasia. So, just like how I've told you all, here it is pretty normal. In CIN1, which I had shown here as grade 1, 1/3, you can see a little bit of 1/3. Here it is almost 2/3. In CIN3, the C2 and severe dysplasia are put together as CIN3. And you find in CIN3 in severe dysplasia, few cells are still normal, but in situ, all the cells are dysplastic. And in invasive carcinoma, you find them moving out of the basement membrane. The basement membrane from where they were regenerating, it's breached, broken. Now they are dysplastic and they are moving and invading. So it is progression of cervical cancer. I hope so far I've made myself clear. LSIL, I've written the full form over here. It's low grade squamous epithelium, and this is high grade squamous epithelium. So low grade is only when it is CIN1. From CIN2, we call it as high grade squamous epithelium. Wonderful. Let's go ahead. So, mild dysplasia, CIN1, classification LSIL, 1/3, moderate 2/3, HSIL, severe more than 2/3 HSIL, carcinoma in situ is full thickness HSIL. Another interesting thing that you will capture in this slide is, because HPV is tending to invade the squamous cell first, the transformation zone first, you often get cervical adenocarcinoma, epithelial gland cells of the cervix. Okay? And let us remember one more thing, that when a person gets an HPV infection, and by the time you develop CIN, it takes about 10 to 20 years. So the progression from HPV infection to developing CIN You have a substantial amount of time of 10 to 20 years. Isn't that sufficient for you and me as healthcare workers to identify women having HPV and to try and give them the vaccine and prevent them from getting CIN? Isn't WHO and all the team very, very thoughtful for calling it for eradication? Because they have studied the natural history of the disease, they have understood how HPV gets in, how HPV stays, how HPV makes the cells dysplastic, and how, after becoming dysplastic, how CIN develops. And once CIN develops, then it goes on spreading. So by the time you have an infection to CIN, 10 to 20 years is a great amount of time. How did they come to know about this 10 to 20 years? So there were two different studies being done, cross sectional studies being done. There were two cohorts. In one cohort, they were trying to see the time span to measure the rate of high risk of HPV infection and the rate of cervical cancer in the other. So in the group, the broken line is talking about cervical cancer and the unbroken line is talking about the HPV infection. So look at the age, look at the x-axis, it is talking about the age group. And of course here, the HPV prevalence. Now when you look at the unbroken line, it is showing a peak anywhere around 26 to 27. Okay, that means women have got a high peak of HPV infection during that time. It can start somewhere around 20, 21 years. Peak is around 26, 27 years. Then the peak starts coming down and then it plateaus off. So the chances of getting HPV infection almost becomes less at the age of 35, very, very minimal. Versus those who have got cervical cancer, the chances of getting cervical cancer peaks around 35, 36 years. It is almost therefore the peak of 26 to a peak of 36, 10, around 10 plus years, which is sufficient time to take care of our ladies. So cervical cancer is most frequently diagnosed in women between the age of 35 and 44, with the average age being 50. It rarely develops in women younger than 20. Bimodal age distribution cervical cancer, first peak is 35 to 40 and the second peak is at 60 years of age or 65 years of age. So again, I'm repeating this. This is very significant for us to remember because these are the women that we need to target at. Frequently, women are diagnosed at 35 to 44, but there is a bimodal. So therefore, the average is 50. But there is a bimodal age variation that we can see. So the first peak is 35 to 40 and the second peak is at 60. Okay, wonderful. Let's go ahead. What are the risk factors? The risk factor is HPV that is got sexually transmitted and the risks are highest in women who are not using condoms and who have multiple sexual partners. Let it be very clear to all of us that this HPV infection will always not cause cervical cancer. It's because I'm taking good care of myself. I don't have many sexual partners. I must have got a little HPV here and there, or I must have got a strain which is not giving a cervical cancer, or I must have got very virulent things. The body takes care of it. But HPV infection can cervical cancer is definite that 16, 18 and 35 as I've told you. The risk increases depending upon the type of HPV as we have just discussed, the length of infection. So if I have a strong virulent infection that has entered in my body and has stayed for a long period of time because I was ill, sick, not taking care of myself or immunocompromised, then yes. My environmental factors, I've been a person who is a smoker, who's taking alcohol, taking tobacco, living a lavish life, living a life taking a lot of high lipid food and all the junk food, then my body is not going to be in a good healthy condition, taking stress and all. I am certainly going to get the cancer. the cancer. And if I'm vaccinated, let's remember immunization against several HPV types linked to cervical cancer is there. Okay, let's go ahead. So the risk factors are summarized here. Lack of regular cervical screening. Now let's remember this is very important. I'll show you all in a slide, next slide, when to start the screening. So if I have to start the screening, and I've told you all the two primordial peaks. So if we have to start the screening, and if I don't do the screening, I miss it. I miss it. Lack of regular screening, I've got more chance of getting cancer. Were I to screen myself, I would have been able to eradicate it there and there. High sexual behavior. I've started, I mean, a woman starts her sexual behavior much earlier, less than 20 years of age. Early marriage, so you have more relationship. Multiple childbirths. Multiple childbirths, more changes in the estrogen progesterone. I do not want to tell you normal estrogen progesterone gives cancer. I only want to tell you variations and surges are changing the media of the vagina, which can make it more prone for HPV infection. Frequent change of partners, promiscuity and prostitution, history of STDs, herpes, family history of cervical cancer. So when you talk about family history of cervical cancer, I put them into that small proportion of population that I told you who can get cancer without HPV. So if there is hereditary chance of getting cervical cancer in my family, I have that predominant in me. Low socioeconomic condition per se because of poor hygienic conditions and more sexual relationship. Long-term use of OCP and diethylstilbestrol. So again, I'm coming back. A lot of variations in estrogen and progesterone in your body, just like how you have more children, has got more chances of cervical cancer. And age, as I've told you, 30 to 39 and 60 to 69 years. The mean age is 51.4 years. It is more common in Africans. Okay, so this summarizes everything that I've covered so far for you all. I've told you all in the pathogen, I've told you all, and this is a summary of the pathogenesis, that sexual activity predisposes a woman to HPV exposure. And it is going to go and affect that particular area, which is called as a transformation zone. And in the transformation zone, I told you all there is squamous differentiation. You also have endocervical columnar differentiation. So if it is squamous intraepithelial lesion. If it is low grade, I've told you all about the grades, that is 1/3 affected. So there could be HPVs who are high, but they are smaller in number, or there are low rich HPVs, and I don't have other cofactors as smoking, OCP, high parity, altered immune status, host gene alterations, and lesser time. So I don't have all those things. I can still go into invasive squamous carcinoma. They can be high grade. With all this, I will go into invasive squamous carcinoma. If it is endocervical columnar differentiation, that means the intraepithelial lesion, adenocarcinoma. So high risk HPV 16, 18. I'm sorry, this is 35. And of course, presence of all this will cause invasive adenocarcinoma. So far, I think I should be good to go. I have made many things clear to you all. I have told you all cervical cancer is because of HPV. I have told you all it's because of 16, because of 18, because of 35. I have told you all about the transformation zone. I've told you all this transformation zone. All of us have gone through a phenomenon of metaplasia. So more prone to develop any kind of affection in this area. HPV go and sit over there, put in their DNA, cause release of 6 and 7 proteins, and then change the whole phenomena of cellular growth. And that's how cervical cancer happens. So this is a dysplasia, early dysplasia, small. This is non-invasive cancer. It is not moved out of the basement membrane. Once it moves out of the basement membrane, it is invasive carcinoma. So you can have exophytic growth, that is cauliflower-like, which I've shown you all over here in the last picture. Endophytic, which can be ulcerative lesions. As I've told you all, the tumor can spread through direct. So if it is here in the cervix, it can go up to the uterus, cover the whole cervical canal, go up to the uterus, go below into the vagina. Then lymphatic spread, blood spread, and transcoelomic spread. Okay, so we have squamous cell carcinoma, almost 85 to 90%, and adenoma carcinoma, 10 to 15%, and these are the various types. We can also have mixed carcinoma. How do the women present to us? So the women present to us, they could be either asymptomatic or symptomatic. Asymptomatic early stages, they could be discovered accidentally when they have come for their family planning clinic procedures. So what are the symptoms? The first abnormal sign will be abnormal vaginal bleeding, especially after sexual intercourse. So let's remember over here that when the cells are growing and there are blood vessels which are trying to angiogenesis, which is trying to nourish the cells, which is coming from our body only, these blood vessels, angiogenesis, are thin. And because there is proliferation of the cells, they are not densely together. So, moment you touch them also, they start bleeding. Those blood vessels are more thinner and more tortuous. And because of any kind of friction, they can start bleeding. So, typically, a woman gets this after a sexual intercourse. There could be vaginal discomfort or vaginal discharge with an unpleasant smell, especially when I told you all there is ulcerative lesion, that means there is a secondary infection that has set in, and pain during urinating. So, pain during urinating comes in when it has affected the bladder. And if it affected the bowels, you will have constipation. And of course, bloody urine, again, the bladder. So these are the typical symptoms that women come with. There could be other symptoms like excessive loss of body weight, micturition symptoms, as I've told you all, dysuria, frequency in urination is increased, urinary incontinence is there, vesicovaginal fistula developed, rectal symptoms like rectal pain. There could be pedal edema because of the structure, the tumor that's keeping on growing, the return flow from the legs reduce, and therefore the person can have pedal edema. There could be pain, dyspareunia, low backache, deep pelvic ache, and sciatica, back again because of the pressure symptoms on the nerves that are there. A speculum vaginal examination will show the lesions. It could be proliferative, cauliflower-like. It could be very vascular and can be a friable growth that you can find it is breaking and it bleeds on touch. It can be ulcerated with flat indurated areas and can have offensive vaginal smell. Now, this is what is about screening. I told you all women should get themselves screened, and this is another message that I want you all to carry back home and keep on you. Pap smear needs to start at the age of 21. Because I told you all in the graph, 24 is the peak age when HPV infection is at its peak. And just before that, the woman has high chances of getting infection too. But the peak is 24. So it has been researched and said 21 to 65 years. Every 3 years, a woman must undergo pap smear. If a woman has any abnormality, the doctor will tell her when to come. It will not be after 3 years. But if the pap test is normal, I go back after 3 years and repeat my pap test. So I need to do this till the age of 65. The FIGO guidelines is woman of age 21 to 29 years once every 3 years. And woman of 30 to 65 do a pap, but also do an HPV DNA testing. So this HPV DNA will pick up if you have HPV infection. So a co-test is suggested once every 5 years if it is negative. In women above 65 years, no pap test is indicated if last 3 pap smears are negative. Now, if the pap test is showing any kind of dysplasia, then it is essential that a colposcopy is done. So in the colposcopy, these cells are picked up and sent for lab investigation cytology. So cytology will be able to pick up whether it is early cancer. Yeah. So May 2018, WHO called it a world without cervical cancer. But when they said a world without cervical cancer, they have said the cases will be less than 4 per lakh women years. So they have set the control targets 90, 70, 90. Call for elimination. 90% of the girls fully vaccinated with HPV by 15 years of age. 70% of the women screened for HPV at 35 and 45 years. And 90% of the women identified with cervical disease received treatment and care. Let's understand cervical cancer fulfills the criteria of screening and fulfills the criteria of elimination because it's an important public health problem. We have understood the natural history. We recognize it at an early stage. We have facilities for diagnosis. The tests are suitable and the cost of screening is not much. So we have VIA and VILI. So it's a quick 1-minute test where you apply 5% acetic acid or Lugol's already. Precancerous lesions with cancer glycogen. Thus, the lining will turn yellow after Lugol's application. That is VILI test. With Lugol's iodine. Visual with Lugol. And precancerous lesions with a high ratio of intracellular proteins, they turn white when combined with acetic acid. It has been said very, very clearly by WHO that always ensure a woman comes and multiple approaches of care are given. For example, if a woman is coming for screening in the family planning clinic or comes with some symptoms, you are screening her. You find her positive, don't let her go home and tell her to come for ablation later. At the same time, there and there, do the biopsy, do the ablation so that a woman out of fear may not come back and become a full-blown case later on. So don't miss the woman early. Later on, in case if she requires LEAP or conization and you want to send her to a higher center, ensure that you do a good follow-up and send her. And women who require tertiary care only must go to cancer centers. So multi-approach screening and treatment is what is warranted. Now let's come to something that's interesting about HPV vaccine. Now in HPV vaccine, we know this is something like a COVID vaccine only. So it is morphologically identical to the intact virus. It helps to generate neutralizing antibodies in the blood, which can reach the virus at the site of infection. Antibodies will neutralize the virus and prevent entry into the cells. Something like a bacteria. So if you put a live bacteria, which is sort of minimized in its virulence, it is going to produce antibodies and antibodies are going to attack the bacilli. The same effect is there over here. So vaccine can be given prophylactically when a person is normal, not having the infection, or maybe when the woman could be having some amount of HPV infection. Later on, it can be given therapeutically also because this is going to target the oncoprotein which HPV was producing, that is E6 and E7. So it generates antibodies and tumor growth inhibiting cytotoxic lymphocytes. But this area is not taken care of today. Today, nobody is bothered of giving HPV vaccine once the CIN is developed because the best is surgical method. Prophylactically is what WHO and the world over is targeting at. Globally, the first licensure was given in 2006. In India, it is in 2008. So we have bivalent, quadrivalent, and nonavalent vaccine. Bi, 2, 16 and 18. Quadri, 4, 6, 11, 16 and 18. And nonavalent is Gardasil 9. It is protecting against 4 strains, 4 HPV as well as 5 additional, that is 31, 33, 45, 52, and 58. These are safe, highly immunogenic, and 125 countries have introduced HPV vaccine in their national immunization program for girls. 47 countries have put it for boys also because the infection comes from boys. In India, we have both Gardasil and Cervavac. Cervavax is bivalent, Gardasil is quadrivalent. So we have both bivalent and quadrivalent. Now, there are countries that are following one schedule, two schedule. Some people are starting 9 to 14 years, some are starting 15 to 20 years. Basically, these are the doses. So they say start the first dose at 0 and give the second dose 5 to 13 months later. Or first dose 0 month, second dose 2nd month, and third dose 6 months. There are others also, like first dose at 0 month, second dose at 1st month, and third dose at 4th month. Longest is first dose 0, second dose anytime in between, and the third dose at 12 months. In India, it's going to come. It's going to come as a form. It is, and when I say it's going to come, it's already there. So people are taking this vaccination privately. It's not come into our national immunization program. But when it comes, our OBG team wants it to be given in 6 months' time. So the first dose given, and then 6 months later, the second dose given. The third dose would be kept as optional, just like how we had a COVID vaccine. Okay, so it is said, together we can ensure, enforce, bring forth, and form. Ensure that every girl receives HPV vaccine, preferably by the age of 10 to 15 years. This is very, very important. 10 to 15 years. As I told you, some have started at 9, some have started at 15 years. And WHO has very clearly told us that they want it to be given 15 years. Okay, fine. So that makes our HPV vaccine very clear. Now, it's safe, it's not going to give much of problems. We want to enforce the message of screening after 30, preferably HPV testing. As I told you, in India, they have very clearly said, start at 30, DNA test. Bring forth survivors who can stop, who can talk, can be influencers, and form public-private partnerships. Primary prevention is for girls 9 to 14 years, HPV vaccination. So in India, when it's going to come, it is very clearly going to come at the age of 9 years. And WHO has changed this as the latest one. So the latest, which they earlier said is 15 years, now is 9 to 14 years. HPV vaccination clearly between this age. 2 doses. Though there are researchers which are saying even 1 dose is okay. But in India, it's going to come as 2 doses. Girls and boys, for both them, health information is important. Tobacco, big no. Sexuality education should be done. Condom promotion should be done. Those who are engaging in sexual activity. And male circumcision is written but not practiced. Secondary prevention, women who are less than 30 years, screening is important with HPV. Screening is going to start at 21 years with just doing pap smear. At 30, must start DNA test of HPV. And all women should get the treatment for precancerous lesions at the center there and there. And of course, there are other therapies, that is surgery, radiotherapy, chemotherapy, and palliative therapy. So these are the WHO guidelines for screening. They say that NAT test can be done. These are molecular tests. DNA test can be done. Molecular test. HPV antibodies can be done. Oncoprotein 6 and 7 can be found. Cytology test can be done, which is done in India, pap smear, with VIA and villi, and visual inspection with colposcopy. Okay, there are barriers to cervical cancer screening. Inadequate cervical screening is because of lack of infrastructure, lack of manpower, lack of funds, lack of awareness. But let's remember it is preventable. This is just a pap test where you can see the cytoplasm is much larger than the nucleus as compared to the abnormal one. So when cervical cancer is diagnosed at an early age, the 5-year relative survival is just 91%. Earlier you get it, you find the survival is very high. When it is late, it is 9.3, 22%. Stage-wise management of CIN. It is said CIN 5 years will definitely become CIN3 and a cervical cancer. As we have said, the cycle of growth. So, DNA testing, pap testing is very important. Normally, when you get a woman early, ablation, you ablate that area or do cryotherapy. And in CIN, there's loop electrosurgical excision procedure, CIN3 also lead. When CIN3 comes in, then there is hysterectomy. Laser ablation is best if CIN extends to vaginal fornices. What is the care that we have to give? We tell the woman to rest, wear sanitary pads. They can have mild cramps, spotting, not to douche, limit activity, take pain relievers, report back if there is heavy bleeding, clots, foul smelling, fever, abdominal pain. So this is a cryosurgery machine. All that you do is this area has been all cryosurged out. Fine. This is a cold knife, so cold conization is done. Again, a laser knife to remove it off using laser. Leap, as I told you all earlier also, it's a wire which is used to clear that area like cryosurgery. And then there are other surgeries. So these are the various stagings. I can leave this, the PPT is there with Astron, you can pick it up from there. These are the stagings that are there. So normally what is done in early staging, as I told you all, deep cryosurgery, but later on, when it is limited to cervix and upper 2/3 of the vagina, and the tumor is less than 4 centimeters, surgery starts here. Before that leap comes in. Greater than 4 centimeters, concurrent chemoradiotherapy is required. And of course, when it has spread, you definitely require a major surgery. Radiotherapy also is there. External radiotherapy with cesium. Brachytherapy is when you have these tandems and ovioles put. Tandem is the one which is in the center, goes up to the uterus, and the ovioles on each side. And then the radiation material is put inside, and local radiotherapy is being given. Side effects of external beam radiation is a person can have fatigue, stomach upset, diarrhea, nausea, vomiting, skin changes, cystitis, that is the bladder is inflamed, vaginal pain, menstrual changes, low blood counts. So pancytopenia can be there, anemia, neutropenia, thrombocytopenia. But all these can be reversed after some time. Similarly, in brachytherapy, there is fatigue, diarrhea, nausea, irritation of the bladder, low blood cell counts. Often brachytherapy is given right after external beam radiation therapy. For surgery, we have simple hysterectomy. So the uterus and the cervix is removed, but the other structures are not removed. In radical hysterectomy, you will find the parametria and the ligaments are also removed. The cervix and the upper part of the vagina next to the cervix and the lymph nodes are removed. In a modified radical hysterectomy, much of the vagina and the tissues next to the uterus are not much removed. Lymph nodes are usually not removed. If they are affected, then they may be removed. Trachelectomy is just removing of the cervix and the upper part of the vagina. This is the picture out of here. Upper part of the vagina, the cervix is removed. And pelvic excision, when everything is being removed in the pelvic region, in terms of the uterus, the cervix, the vagina. So it's something like a radical hysterectomy. In addition, The bladder, vagina, rectum, and part of the colon are also removed. There are various chemo drugs. Common drugs that are being given is cisplatin, carboplantin, paclitaxel, and fluorouracil 5-FU in combination of threes or twos. And most of these drugs attack the cells, abnormal cells. The chemo side effects are hair loss, mouth sores, loss of appetite, diarrhea, nausea, and vomiting. There can be menstrual changes, premature menopause, infertility, and of course, pancytopenia. The nursing responsibilities, we need to monitor for these infusion reactions, manage these side effects with, of course, drugs, and ensure proper hydration and electrolyte balance. Educate the patients on the importance of reporting unusual symptoms. Let's remember, immunotherapy is boosting the immune system. So when I told you about the cell cycle, the P6 and the P7 were escaping the immune system. Here the immune therapy drugs will make the immune response strong. So the T cell response against cancer, anti-tumor immunity, immune evasion by tumors, proliferation of T cells and natural killer cells. So you will see all these as enhancing the immunity so the person is able to fight the tumor that has developed. Let's remember, immune therapy can also give fatigue, can have certain adverse events like colitis, pneumonitis, hepatitis, rash, infusion reactions, but these can be taken care of in a short duration of time. Targeted therapy will act basically on a given area. So, for example, if a cell is growing and there is P6 and P7, they will work on those proteins, or they will work on certain tyrosine kinase inhibitors will work on tyrosine kinase inhibition. So they are working on specific areas so that the entire tumor can be removed off. So targeted therapy. They also have side effects like diarrhea, skin rashes, hypertension, liver toxicity, cardiotoxicity, bone marrow suppression, but these can be managed in a due course of time. Nursing responsibilities is we need to monitor for these infusion reactions. We need to assess for signs of immune-related adverse events. We need to educate patients on the importance of adhering to therapy schedules. Monitor the lab values like kidney, liver function, and evaluate for signs of organ toxicity in case of cardiac, pulmonary, or hepatic toxicity. Symptom management of common side effects like fatigue, diarrhea, and rashes is being done with drugs and with, of course, a lot of uh, a lot of things like giving them proper kind of diet. Educating patients on when to come for medical follow-up and supporting the patient emotionally. Palliative care comes in when the patient has got severe metastasis. The pain management, opioids is being given. For symptom control, like managing bleeding, discharge, nausea, and lymphedema, a lot of psychological support, nutritional support, wound care, because there could be vesicovaginal fistulas, necrotic wounds could be there, end of the life care with dignity and comfort, and palliative radiation to reduce the pain in case if need be. So the subjective data while caring for a patient, the data we correct is vaginal bleeding, as I told you all, watery, bloody vaginal discharge, pelvic pain, fatigue and weight loss. And the objective data is abnormal findings on pelvic examination, pap test, imaging studies, and biopsy. All this confirms the cancer cells. The nursing assessment we'll be doing gynecological assessment for these specified signs, pain assessment, nutritional status assessment, psychological assessment, and our diagnosis would be acute pain, altered sexual function, risk of infection, and anxiety. So it's important that in nursing evaluation for cervical cancer, we manage pain management is effectively done. We need to routinely evaluate the pain levels and effectiveness of pain management strategies. We need to assess the patient's adjustment to changes in sexual function and comfort and monitor for signs of infection and effectiveness of preventive strategies. Evaluate the comprehension of condition, treatment plan, and coping strategies. To summarize, as I told you all, cervical cancer is in the cervical region caused by HPV infection. These are the gradings: 1/3, 2/3, a little more than 2/3, CIN, and invasive. I've told you all that we can prevent it with HPV vaccine starting at the age of 9. Screening should start at the age of 21 with a pap test. Precancerous lesions can be cryosurgery done. Conization can be done. Wherever the area is abnormal, that area cone can be removed, conization. And surgery, hysterectomy, various type of hysterectomies. In conclusion, let me highlight the newly developed motivational slogan: illuminate, participate, and liberate. We have to illuminate our knowledge and skills about the facts of cervical cancer. Primordial prevention is through HPV vaccination. Primary prevention by maintaining good menstrual and sexual hygiene. Secondary prevention by screening and treatment of precancerous stages and cure of these early lesions. Tertiary treatment, disability limitation and rehabilitation. Palliative care. So let's participate in awareness and health education programs as HPV vaccination camps, screening, encouraging compliance by the community, following medical guidance and follow-up schedules, and to eliminate is to reduce the prevalence of cervical cancer to less than 4 per lakh. My motivation, community commitment, and global diplomacy. To conclude, we will illuminate all our buildings with tea light on November 17 every year to symbolize ourselves as community captains for elimination of cervical cancer all over the world by 2030. Thank you. These are my references.
Okay. Hi, everyone. If you have any question or doubt, so please ask.
Few things I've told you all is cervical cancer, cervix, HPV. It's because of HPV. It's because of 16 and 18, because of 35. You get it at early age. So early vaccination, screening should start at 21. At the age of 30, we must go in for DNA testing. And of course, early stage, early management, where it is just deep conization, cryosurgery, a cone biopsy. Later stage, it is hysterectomy, various types, depending upon how invasive it is.
So now our senior counselor, Charul ma'am, just giving a vote of thanks.
It's my privilege to extend a heartfelt vote of thanks to Ms. Rita ma'am for an insightful and enrichment webinar. On behalf of everyone present here, I sincerely appreciate the time, effort, and expertise you have shared with us today. Your knowledge and guidance have truly enlightened us, and we are grateful for the valuable perspectives you provided, ma'am. The session was not only informative but also engaging, leaving us with a deeper understanding of the topic. Your passion and clarity in delivering complex ideas have made a lasting impact on us. A big thank you for organizers and all the participants who made this webinar a success. Ma'am, we truly appreciate your generosity in sharing your wisdom with us, and we look forward to more such inspiring sessions in future. Thank you so much, Rita ma'am.
Thank you so much.
Thank you everyone for your valuable time. आई थिंक आपके काफी सारे डाउट्स क्लियर भी हुए होंगे. मैम ने बहुत अच्छे से एक्सप्लेन किया है सर्विकल कैंसर, जो कि बहुत बड़ा टॉपिक है. उन्होंने हर चीज बहुत अच्छे से बताई है, प्रिकॉशंस भी बताए हैं, कैसे उसके प्रिवेंशन वगैरह होता है. जो चीजें उन्होंने बताई हैं आपको सारी, उन्होंने जो पीपीटी दैट इज अ वेरी लवली, बहुत एक्सपैंड करके हर चीज बताई है. एंड आगे आप कौन से
बहुत अच्छा बताया है.
ओके, थैंक यू सो मच. एंड आगे भी हमारे वेबिनार्स होंगे. आपको कौन से टॉपिक पे चाहिए तो आप हमसे शेयर कर सकते हैं. एंड ऑल्सो वी हैव ऑन्कोलॉजी कोर्स, सर्टिफाइड कोर्सेज जो 3 months के हैं, जो आप रिलेट कर सकते हैं. जो भी इंटरेस्टेड होगा अपने रिलेटिव काउंसलर से बात करें. तो हमारे पास काफी सारे कोर्सेज हैं और अभी हम आने वाले टाइम में काफी सारे कोर्सेज लेकर भी आ रहे हैं. सो बी कनेक्टेड. ओके,
ओके,
And
और
the thing
ऑन्कोलॉजी
is,
के लिए बीएचएमएस चलेगा ना सर्टिफिकेशन?
sorry?
BHMS is a bachelor in homeopathy.
यस यस.
No, dear, you need to have GNM or BSc nursing in your profile so that then only you are eligible for the course.
Yeah.
ओके ओके ओके, नेवर माइंड. थैंक यू थैंक यू.
Thank
Okay,
you.
Dina, thank
और
you so much.
और ये सेमिनार का सर्टिफिकेट भी आ जाएगा ना?
Yes, मैम आपको सारे डिटेल्स मिल जाएंगे व्हाट्सएप पे. ओके
ओके ओके,
ओके,
थैंक यू.
थैंक यू सो मच मैम. थैंक यू. ओके.
Thanks.